physical exercise, specifically here in Oklahoma, we're still pretty spread out as a state. And so I could not walk or bike to work because I live, well, I guess I could, but I live 50 miles away and that would be bad for my 50-year-old body. So, but in other states where things are much more centralized, there's more walking, biking to work, to school. And so and in other countries, that is more the norm than an outlier. So physical education in schools has decreased significantly. It used to be required at all age groups, and there are still some regional universities that require it as college courses as well. But as funding pulls away from education, they focus on the core classes, math, science, English, and social studies, and are pulling away from extracurricular activities, physical education, and then of course the arts. And then socioeconomic status also plays a role in obesity. More often than not, things like lack of access to parks and biking, safe places to go and get physical exercise, and also trying to stretch the dollar. So maybe using foods that are less amounts causes satiety faster. So pastas, breads, and then things that are also less expensive and can be bought in larger quantities. So like cans of fruit, canned vegetables, cans of things less fresh. Fresh is usually more expensive. So I went backwards, like by 3 slides. So there's also some psychosocial factors that play into obesity. The psychosocial factors include as children being given food as a reward, or we actually have a lot of holidays that are surrounded based on food. Thanksgiving specifically is literally about eating. So, and then birthdays, we usually have birthday parties with cake and ice cream and pizza, some sort of, it's also centered around food rather than around playtime. And then more and more we see distracted eating. So people are multitasking. So they're eating while they're working, eating while they're playing video games, eating because they're bored. And so mindless eating is really specific to not paying attention to when satiety occurs. Satiety typically occurs within about 20 minutes of the beginning of eating, and people that eat super fast or eat while they're distracted miss those satiety cues and continue to eat beyond what their body actually needs. There is a genetic link. We said there are potentially genetic factors that could increase their risk of becoming obese. Genetics plays that role, and then also it plays into ethnicity. We actually see obesity occurring more in some ethnic groups than others. So we talked just briefly about, here in Oklahoma, our ability to get physical exercise is decreased because of the way we're spread out. And then the country or the states that have more centralized development around big cities, and then nothingness out in the middle. And so they're very concentrated. They have better infrastructures. So they've got public transportation, places for biking, places for walking. So this is just kind of a picture for you to see where obesity is occurring. So these places that have far out spaces, like North Dakota has got a higher rate. There's not a lot of room for getting around. And then spaces that are known for the types of foods that they're known for cooking. So high fats, high oils, frying their foods. So these this area here is very well known for those types of foods. And then the areas that are more known for having infrastructure, and being very close together here in the Upper Coast, everybody's packed in and they are all very centralized. Where they work, where they live is all really closely together. And so there's going to be less instance than in the states where it's more spread out. So talking just a little bit about those disparities. Additionally, again, talking about ethnicity, we do see higher instances of obesity as a ethnic component, both because of culture and because of genetic components. African Americans, Hispanics, and Native Americans have a higher level of obesity overall than do Asians or Caucasians. And then on top of that, women are more obese than men as a general rule. They have more lean muscle mass, and so their metabolism tends to be faster. And so, but as a whole, you'll see that obesity is higher in some ethnic groups. There is a chat. Let's see if I can get to it. Yes, also again due to socioeconomic status. Correct, Rachel. It's very good. I think that was on that slide previously too. Low socioeconomic status, and those right now in America, those ethnic groups are associated with having lower socioeconomic status and decreased ability to raise themselves up. So childhood obesity is also significantly on the rise. We are the sixth worst in the nation, and you see that we have about a 13% rate in our infants and toddlers, and then in our teenagers, we are at about 18% of our teenage population is diagnosed as obese. So one of the biggest factors with that, not only is it looking at the behavioral factors that we can adjust, meaning that if they grow up with food as a reward, if they don't have self-limiting behavior, if they're not getting physical activity, that's going to lead to obesity just in children. That carries through to adulthood. And in fact, if the satiety triggers are damaged over time, they overeat, they ignore their satiety triggers, that actually can become lifelong as well. So catching it in childhood and changing those factors in childhood to reset that satiety trigger between the stomach and the hypothalamus, that makes a huge difference in their ability to maintain a healthy weight in adulthood. So when we're talking about how do we determine if someone is obese, for many years they use the body mass index. And body mass index is the patient's weight in kilograms divided by meters squared for their height, or it's like pounds times 703 divided by height in inches squared. It is not important for you to know that calculation. That's something that dietitians are going to use, but just FYI, that's how we get that number. It is the same whether you do it one way or the other. And then the number we gather from that then puts them in a category if they're underweight, normal, overweight, extremely obese, or morbidly obese. Now, what we're really understanding too is that no two body shapes are the same, and that we can definitely see as a body changes over time, they may appear to be obese when they've lost height, or they may appear to be normal weight when they're truly underweight because of their the muscle mass that's there currently. So body mass index is one indicator, and it is kind of the indicator that is still used currently by most physicians. But a better way to make sure that we're really classifying a patient appropriately is to include not only the body mass index, but looking at their waist circumference. And so we're concerned about the risk for comorbidities when their waist circumference is more than 35 in a woman or more than 40 in a man. Very specifically, cardiovascular disease is linked to waist circumference, the presence of it, through research. So there is a significant relationship. And I know you guys are going through research right now, so those words should mean something. Significant relationship means that evidence did support that those two are linked. And then the other is the waist to hip ratio, and they're the less than 0.8 versus greater than 0.8. Now, those numbers that you see on the screen there, those are numbers that you should know as a nurse. So we kind of we kind of keep all of those numbers in our minds when we're talking with patients, because anytime we identify a patient as obese, we do need to be doing some patient teaching involved with that. So I would expect that you would see these numbers in some form on our tests and also on NCLEX, because it's going to ask, do you know that baseline information? Because if you can't recognize a patient as obese, that puts their safety at risk and their health at risk. So do pay attention to these numbers, not necessarily how you get to them. Body shapes, we've also seen a lot of research done on body shapes specifically. So there are specific health risks associated with where the distribution of fat is on the body. So I said just earlier that heart disease is really associated with that waist circumference, and we see that android body shape, heart disease. So you see that mid-truncal obesity is where the adipose is really centered in the mid-abdomen, and that's an increased risk for heart disease, but also diabetes, breast cancer, endometrial cancer, and then differences in hypertension, and of course with diabetes, that is decreased insulin sensitivity. So the top picture of the gynoid is actually more of that pear shape where most of the weight is distributed through the hips, buttocks, and thighs. That is actually more common in women than men, and the android is more common in men than women. Hence the names gynoid and android. And the gynoid is associated with osteoporosis, varicose veins, and cellulite. Okay, so it is not specific. It's not that a man or a woman can't be the other. That is just what we see. When we see this body type, they have a higher risk for these others. So a patient with gynoid distribution of fat can absolutely still have diabetes and heart disease. Okay, so just knowing that what they're at a higher risk for based on that adipose layer. All right, and does this make sense? So all of your fat is stuck here in the middle, nearer to the heart. So that increases your risk for heart disease. It's also centered in the main organ structure. So fat is going to surround those main organ structures. So the pancreas that produces insulin, and then the vena cava and the aorta are right there central. So if there's a lot of adipose tissue surrounding it and squeezing it, that's going to increase vascular resistance, which increases our risk for hypertension. Whereas you have your gynoid that is lower in the trunk, in the thighs, the hips, and the buttocks. So there, we're going to have an increased pressure on the venous system going from the periphery up varicose veins. Osteoporosis, that's going to be just pulling from, that's a large bony structure that you have there. The pelvis is our large bony structure, and we're pulling away from that and packing it with adipose tissue. And then cellulite, that's where it settles in. It usually settles into the thighs and the buttock area. So this is something that you should review. I would not memorize this by any means, but just looking at, we talked about comorbidities. Well, here they are. Obesity affects every system of the body. And so just looking through here, it can cause depression. A lot of that related to the negative bias that we have in society about a patient with with obesity. And then the endocrine can cause diabetes, can cause metabolic syndrome, which you go over in critical care, and metabolic syndrome in adult 2 also puts you at increased risk for heart disease. Respiratory, when there's adipose sitting on the lungs, it can actually cause changes in the ability for the patient to take a good deep breath. And so you can go through these and look through them, but it affects every single system within the body. So what do we do when we have a patient that we've diagnosed with obesity? So our main goal is to try and pull them back into a normal weight. And so we know that, and you learned through your nutrition course that a multimodal approach is the most important and most effective way. So we're going to look at what are they eating, how are they eating, when are they eating. Then we're going to look at what is their exercise pattern. We'll look at what behavior modifications do we need to implement. There are some circumstances, typically in excessive or morbid obesity only, that they will add drugs, amphetamines or non-amphetamines, to try and aid in weight loss, rapid weight loss. And then also surgical interventions as well. Again, when they have excessive or morbid obesity and life-threatening or life-limiting comorbidities. So morbidly obese plus have diabetes and hypertension and cardiovascular disease. So the risks of surgery are not outweighed by the risks of them continuing to live in an obese state with the disease processes they have going on. So again, looking at nutrition, remembering back from that course you took, dieting is not appropriate. We want to have a well-balanced meal plan. And so it is important that when we talk with patients about how to combat obesity, that we steer them away from what we consider fad diets. So the keto diet, Atkins diet, basically the same thing. Those high protein, low carb diets, the ones that drink all your meals for a week, or fasting for multiple hours in a day, 16, 18 hours a day. The problem with those is while they do help patients to lose weight, and because they're changing their habits and maybe getting rid of some of those negative bad foods that they have been eating, those aren't considered sustainable. They're usually pretty strenuous, very strict, and leave the patient feeling hungry, and psychologically are very difficult to maintain for very long periods of time. Now, there are people that do have success with these, but that is the exception, not the norm. And also our concern is there are dangers that go along with these diets as well. They're not meant to be lifelong changes. So teaching them how to get a well-balanced diet allows them the right vitamins, the right minerals, to maintain a healthy body system, and it's more sustainable. It doesn't eliminate. So talking about moderation rather than elimination is more sustainable and something that patients can usually do. Stress causes increases in steroids in your body, which causes an increase in glucose in your body, which causes you to eventually gain weight and redistribute adipose. So continuous dieting that puts stress on the body more often than not leads to imbalances in the weight, big ups and big downs. So talking with them about, we want to make sure that they have that balanced meal, that they have a large portion of vegetables, half the plate of vegetables, and then the other pieces of the plate in proteins and grains, talking with them about getting rid of processed foods, getting rid of sugars. We tell people to shop the outside of the grocery store. The outsides of the grocery store are usually where the fresh foods are, and then the interior of the grocery store is where the more processed foods are. So that's one of the behavior modifications we can do just in their shopping habits. So it is important that they understand that it's not just what they eat, but how they eat that can actually make a change. So again, going back to that mindless eating, that behavior modification of paying close attention to what you're eating, when you're eating, so that you can pay attention to when you're full, is a big change that's important in diet modification. And then, of course, making sure that they're setting those realistic goals. Losing 1 to 2 pounds per week is sustainable, and usually means that they're in healthy weight loss. When they lose 10, 15 pounds in 1 week, that's usually going to come right back on because of the stress to the body systems. And then the more water they drink, we do also have research that links hunger to actual, the triggers for hunger are actually triggers for thirst and dehydration. So we teach patients, if they will drink an 8-ounce glass of water anytime they feel hungry and it's not the appropriate time to eat or snack, then drink a glass of water, wait 10 minutes. If they still have a hunger, grab something healthy to eat. If not, then it was most likely dehydration. So getting that increase in water makes a significant difference in their need to snack. Okay, and so again, along with changing their diet, exercise has to be part of the component in order to increase lean muscle mass, which also increases metabolism and helps the patient to burn fat. It's also good for cardiovascular health. So we want to make sure that they are doing 30 minutes to an hour of cardiovascular exercise daily if possible, at minimum 5 days a week. And then just helping them figure out, okay, take the stairs rather than the elevator, parking further away from the building than they used to. Little things go a long way. And giving them a very concrete goal, 10,000 steps per day, definitely makes a big difference, because they may say, I can't get 30 minutes to an hour of walking in a day. My day is too busy for that. And then they just say, I can't do it at all. If I can't do exactly what you're telling me to do, I won't try at all. So giving them that goal of 10,000 steps per day, they can do it in 10-minute increments, 15-minute increments, whenever they get a break. So it's important to let them know that to focus on the overall goal for the day if they can't meet those intermittent goals. Some people are more directed towards, I need a specific set amount of time. And so you've got to make your plan based on what your patient's needs are. It is important that we make sure that patients that are just starting an exercise program don't go directly into the newest craze in exercise, which is the high intensity training, where they do really strong, heavy spurts of strenuous exercise for a short amount of time. The biggest concern we have is that it can cause injury. So, and also over time, not sustainable and difficult with equipment. There's all sorts of reasons why doing natural exercise is going to be a better option for most patients. Okay, so behavior modification is the third piece. So they have to change their eating habits, change what they're eating, add exercise, and then change their behaviors as well. So we know that journaling, we talk about journaling and nursing all the time. Journaling is a great way for them to visually see what they're consuming. Mindless eating plays a big part in our obesity right now, and having that journaling can help to hone in on what are their eating habits, what habits need to change. Then looking at what triggers them to eat. So eating from boredom. So that's they find through journaling that they're snacking more in the evenings while they're watching TV. So changing what snack they're having, or having a hot tea or a glass of water, something instead of food. Or getting up and taking a walk instead of eating. Those types of behavior changes are going to be key to helping them make changes to reduce obesity. And then also looking at not using food as a reward system, not focusing all their social time around eating. So going on dates with friends, outings with friends that don't center on food, that center on activity instead. Those are ways that we can help them to make changes in their lifestyle to help reduce their weight. So again, we talked a little bit about there is a potential that we may see some drugs being used. Again, they need to have a BMI that's greater than 30 that puts them in the excessively obese. This by itself is not enough. The medicines that are used are meant to be short term, if they are used at all, because there's a high abuse potential with these drugs used for weight loss. So they need to be used in conjunction with diet, exercise, and behavior modification. So there are going to be some side effects that patients need to be aware of with both amphetamines and non-amphetamines. So the appetite suppressing drugs, they stimulate the central nervous system and reduce the hunger triggers. Amphetamines, again, they are not, they were used in the past, but they are not really approved for that. So we use amphetamines for people who have ADHD. That's kind of the main use of the amphetamine category, but they had been used in weight loss in the late 70s, early 80s. high abuse potential and also dangerous. The adverse effects of tachycardia, palpitations, and insomnia are kind of the main ones that go along with amphetamines. Those happen in the non-amphetamine categories as well. These are structurally, chemically similar to amphetamines, but are not the exact same. So they were called the non-amphetamines. So phentermine is probably one of the most common ones that we've seen used. Those are not to be used for more than 3 months. There is an abuse potential with them as well, and have the same side effects that amphetamines do. So definitely not to be used in patients with underlying cardiac issues, which many patients who are obese do have. There is an over-the-counter drug called Senecal or Ally, and what it does is it blocks fat absorption. The negative effects of that is they have steatorrhea, so they have very foul-smelling stools, and also a lot of flatulence, and can have some leakage of because that stool becomes very soft and almost to diarrhea. So it can result in liver injury, the metabolites from that. And then because they're not absorbing their fat, it's just falling through, they're going to need fat soluble vitamin supplements as well. And then Belviq is one that is used not as frequently. It has not been relatively effective. It is not over the counter, and it is an serotonin agonist. So it is used to change the chemicals within the brain to change the triggers to the hypothalamus, and so it keeps that trigger for hunger suppressed. Okay, so we've talked again about the health risks associated with obesity, and so here's a short list again. These are probably the more common that we see. Heart disease again being number 1 and diabetes being number 2. So we do see bariatric surgery being done in the patients with morbid obesity, and again, typically in association with the presence of comorbidities, so significant hypertension, diabetes, heart disease, and they are not good candidates for drug therapy, or they tried the drug therapy and it wasn't effective, or they had too many side effects from it. Bariatric surgery is not the treatment of choice. We don't go straight to that. We do other things first. Patients that are chosen for bariatric surgery have to get under a certain weight, and that is physician dependent. So they want to see that they have the ability to make the lifestyle modifications, because surgery alone will not cure obesity if they do not continue with the modifications required, changing in their meal habits, changing in their exercise patterns, and changing in their behavior component as well. There are a few surgeries that we'll talk about here. Gastric banding is less invasive. It's good for patients that have a lot of comorbidities or are at a high risk for morbidity or mortality from bariatric surgery. It is reversible. It's done laparoscopically, and it literally is they put a band around the fundus of the stomach, which makes the stomach smaller. They can increase or decrease the size of that band through a balloon that they can inflate and deflate. That is implanted subcutaneously, and so then it's accessed in the physician's office, and they can increase or decrease that band. So again, they can pop that band if they overeat, and that is not super uncommon that patients have this surgery and then are not able to maintain the behavior changes and the diet modifications, and they basically pop that band off. It's a rubber band, it's an elastic band, and they pop it. So it is something that is reversible and less invasive, but can definitely has a higher failure rate. There's also restrictive bariatric surgery where they actually remove part of the stomach and create a gastric sleeve. And you can see in the picture when they remove that portion of the stomach, all that's left of the stomach looks kind of like a shirt sleeve. So basically it removes the part of the stomach that triggers hunger. And so it is a pretty successful surgery. This is, and you see up to 75% of the stomach is removed. Now, there are also combination bariatric surgeries. There's a couple of other surgeries listed that are restrictive in your and malabsorptive in your text. The surgeries that you're really going to see on your NCLEX that ask you about those are going to be that lat band and then the Roux-en-Y. This is the most common one used in the US and it's kind of the gold standard. So in this, they literally bypass the actual stomach. They create a little gastric pouch at the distal end of the esophagus and then bypass the stomach and go straight to, and large bowel and go straight into the small bowel. And what that does is it decreases the amount of food that a patient can hold because they no longer have that large reservoir. And it also is malabsorptive. So they don't absorb all the nutrients, which then can turn to fat because it's going straight through to the intestine. So our biggest concern is that they can have dumping syndrome. And you guys talked about dumping syndrome previously when you guys went over GI, right? So our biggest concern is dumping syndrome. It's a really, it's a good weight loss surgery. They have, if they're looking at how to do it also laparoscopically, getting more specific to doing laparoscopic surgery with this as well. And it really does, it doesn't have that high risk of them bursting through that small pouch. It just doesn't allow them to eat, where that band is just a temporary hold. So this is a much more stable type surgery. But that dumping syndrome is where, they just, the nutrients pass through too quickly. And what we do there is a lot of education. If they have this surgery, is really important that they avoid refined sugar as much as possible, or sugary type foods. And our big issue there is that sugary type foods dumped quickly into the small intestine cause a large spike in the blood sugar, and it then causes the pancreas to release insulin, and that results in hypoglycemia. And so the hypoglycemia side, or the symptoms of hypoglycemia: nausea, vomiting, weakness, sweating, fainting. So we ask them to avoid sugary foods. We ask them to eat higher protein foods, lower carbohydrate foods, 6 small meals a day, and avoid drinking while eating to allow slowing down of that movement from the gastric pouch through the small intestine. We actually ask them to physically slow down eating. So all of that dumping syndrome should be kind of a review from previous. Okay.
I have a question on this one. So when patients get this and they show that they can remain a diet, do they get it undone so they can have no? Okay.
No, this is it. Yeah, this is not reversed.
Okay.
No, they keep this. The band is the only one that's reversed. The other two are not reversed, right? So now they do have a lower absorption of vitamins, minerals, so they're going to be on multivitamin and iron supplementing as well. Okay.
I have a question too. Yeah. Are any of these surgeries, are there any complexities if a patient has one of these surgeries and then gets pregnant?
So no, they have, they're going to increase their supplement. They're already going to be on a prenatal vitamin. They're going to eat their 6 small meals a day. They'll most likely increase their protein. We're going to work with the dietitian very carefully and closely, but they successfully grow babies like everybody else. If this surgery, you can have dumping syndrome, but that's not the norm. Okay. So the fact that they are getting small amounts of food and it's going straight to the small intestine, they still get the nutrients they need through close diet modification. And truly, a little bit increase in their protein and a normal diet, they're going to get exactly what they need. good question. Okay, so when we're talking about patients that are going to have these bariatric surgeries, there's some things that we've got to be prepared for. So when patients are having bariatric surgery, they are typically they are very large. So 400 to 1,000 pounds. Those are the types, and they have come down in weight to get there. So most likely they're going to need a different bed. We talked about those special need beds for when we talked about pre-op. They're going to possibly need assistive devices. They a lot of times are no longer walking when they're that large. They're getting back to it, but they're still going to be going from wheelchair bound to maybe cane or walker. So we need to be prepared for that. Also, obesity has a strong link to occlusive sleep apnea. So making sure that they've got their CPAP machine available. And then, of course, just like all other patients, we're going to make sure that we talk to them about their post-operative course and doing that preoperative teaching that they will be ambulating the evening of surgery and then up to 3 to 4 times a day. And we're going to make them do turn, cough, deep breathe. Now, they are going to have a lot of pain within the abdomen itself. And so we are going to make sure that they are very clear on how to splint during that current turn, cough, and deep breathe. Hydration, we want to talk about them that while we need to make sure that they maintain hydration, that we're going to be changing, especially if they have that Roux-en-Y. The way that we do hydration is going to be different. We're not going to be eating with meals. We're going to be watching them very closely with how much hydration they're adding just orally right after surgery occurs. And then in the post-op, additionally, we want to make sure that they've got that larger blood pressure cuff. We're going to be taking vital signs frequently. We're going to be watching their fluid intake, giving them small amounts more frequently. And then when we do these surgeries, we can have significant changes in their electrolyte levels. And so they are definitely at higher risk for cardiac dysrhythmias, at a high risk for thrombus. They're not very mobile beforehand. And so we need to make sure they've got those compression stockings on. Anastomosis leak, sorry. That is always a risk with especially the Roux-en-Y. And what we need to understand is the difference in how they describe their pain. So when they have abdominal pain from incisional, it's going to be sore, it's going to be maybe itching, maybe burning. When they're going to talk about it in a generalized area around their incision. So they're just going to kind of say it's here where I had surgery, aching type pain. If they have an anastomosis leak, gastric contents are leaking out into the peritoneum. They are going to complain of severe, sharp pain, excruciating pain. Their abdomen may become rigid from the inflammation occurring. So it looks very different. So being able to identify the difference between surgical pain or an anastomosis leak type pain. And the main thing there is the type of pain they describe: dull and aching versus sharp and excruciating and sudden. Okay. And so we want to also, they're going to be still very large. And so we want to be careful to make sure that their head of the bed is up at least 45 degrees. That helps to pull the pressure away from their diaphragm from a large abdomen, and also takes pressure off the chest. When you've got a large weight sitting on the chest, it's going to make it harder for the lungs to fully expand. So sitting them up pulls that away, helps gravity to help take effect with that as well. All right. They are often going to have skin folds that we're going to have to move away from incisions, watching their skin very carefully. It's not uncommon for patients with large skin folds to have yeast that grows there. So we're going to be very careful to watch for additional signs of infection. And then we already talked about the diet a little bit, and then of course a dietitian consult. So after weight loss surgery, this picturing here is of a woman who actually went through bariatric surgery, lost a significant amount of weight, and then went in and had some body reshaping done, had excess skin removed, had her breasts lifted, and excess skin removed from there as well. And then so this is not uncommon. They do, because this is quite a successful surgery, they'll have to come back through and take care of if they feel like these excess changes. That excess skin is probably the most common thing that patients are most concerned about after surgery. They'll see it in their arms, they'll see it in their abdomen area, and then they'll see it in their legs. Just over time, the skin is stretched from all of that fat, and the fat goes away, but the skin doesn't go back. The elasticity doesn't pop back. So that's that cosmetic surgery is not super uncommon. Some insurances that will actually pay for it, others will not. It's really dependent on the insurance company. The patients can have cosmetic surgery that does not change their gastric, doesn't change their stomach at all. It just removes actual fat. So lipectomy, where they actually go in and remove adipose tissue, it doesn't regrow for so far that we know about. It redistributes, but once they remove it, that same doesn't go in the same spot. And then liposuction is just another form, and it's more just a contour. Why is there no scarring? So Phoebe was asking about scarring. I'm guessing you're talking about here. Well, you can just barely see here, and there she still has stretch marks. And so these same marks are here, but with a lot of the skin removed, a lot of this scarring is actually taken away too. That scarred skin tissue is actually removed. So, and then the other parts are, that's what a plastic surgeon is for. They are trained to leave as very little tiny incisions and as very little scarring as possible. So, but it is not uncommon. You can just barely see them here. Stretch marks will still be visible on these patients. So, okay, that was obesity. What questions do you have, other than the good ones that you already had? No? Okay.
I don't have any questions. I was just gonna say something about the Roux-en-Y gastric bypass.
Yeah.
The patient that I picked on Friday last week had the Roux-en-Y, and she is now in failure to thrive because the absorption rate is so low, and she has like multiple comorbidities because of the Roux-en-Y gastric bypass.
Yeah. So that is not normally expected, so every surgery runs a risk of complication. It sounds like she got very much one of the very specific complications of it. So, and that makes sense, doesn't it? If you do a surgery where you are bypassing the normal system of absorption into your body, there is a chance that it can have a negative effect. Absolutely. So
I know it's the gold standard, but is it like the last resort, like once everything else doesn't work? Okay.
Yeah. And all of these patients are going to go through a screening process. They have to go through screening for depression. So again, we're going to look at their ability to have those modifications that they have to go through to be good candidates for these surgeries. So they have to show that their some ability. And so like some of our surgeons, and general surgeons are typically the ones that do these surgeries. So one of the general surgery groups I work with, they chose 100-pound weight loss. Patient had to show 100 pounds of weight loss to show that they could go through those complications. And that's a significant amount of body. A significant change has to occur to maintain, to get 100 pounds of weight loss. And they also go through psychological counseling. And so, it is definitely the last resort. Now, I will say there are some that will skip medications because, again, we don't use those. Those were used very randomly, mid-70s to early 2000s, and we've really pulled away from using diet or using drugs to help in that modification. So sometimes we will skip that step. But that would be the only skip that they make. They have to go through, like I said, and do some sort of weight loss. Some surgical groups say 200 pounds, some say 100, some modify it by patient, depending on their ability, So again, diet alone isn't going to change it. What is their ability to exercise? So they may look at their specific, they also look at their specific life and see what changes would be adequate to show that they have the ability to follow through with a lifelong change in how they eat. So, okay, let's now move on to diabetes. How are we doing for time? We're doing okay.